We are live, but I want to switch the internet for our Ritu ma'am to join. Okay, so we're waiting for the internet at the other side to enable madam to join. Yeah. Okay.
Yes, sir.
Yeah. So it's better to continue with the pubic dysfunctions because ilium and pubis is almost the same bone. So it is always easier to see how a pubic dysfunction, especially it is more sensitive area, okay, anteriorly in the groin. Although minimal, it's comparatively, if you see, the number of dysfunctions are lesser. But athletes or gymnasts, those who are working out in the gym for lower limbs, many times we see nowadays that the trainers are helping huge weights and everything. People are not doing as per their capacity. They are doing it too much beyond their capacity in order to get a faster muscle shape or contour. Okay. Or the trainers who have the target that this much girth you reach so that they get the incentives. So unfortunately, we get pubis symphysis dysfunctions, which many patients think that it is natural because of the workout, and you just keep working out, it becomes normal. Okay, and it can progress to any stage, affecting or causing even inguinal hernias during a weight lift, or it can be even pelvic prolapse. So various correlated disorders or the visceral dysfunctions can also come. If you ask me, the role of iliosacral, okay, iliosacral affecting the viscera is more very tough. It is not that much common, except if it is for the pregnancy and childbirth, okay, or abdominal post-operative abdominal surgeries, which directly anyway affect the viscera. But if you see sacrum dysfunction affecting directly, it is there, viscera, because all these structures are suspended with ligaments attaching to the sacrum. And the pubic symphysis, again, it's very closely related to the viscera. So let's listen first, of course, from Ritu ma'am on her clinical outlook, because she has done the pelvic manual therapy specialist course years before, and madam has always been an advocate of that multi-structural comprehensive pathomechanical approach, be it a pelvic floor dysfunctions, or it is incontinence, or it is the postnatal pelvic pain, okay, chronic pelvic pain, not only in women's health but also in geriatric population. Okay, so let's listen to Ritu Sani ma'am. Yes, ma'am.
Yes, sir. As a clinical part, yes, we see the patient as some female patient who are having a problem related to the pubis symphysis. They feel some kind of pain in the groin area, but that pain normally sometimes we mismatch that this is the because of the after delivery, because of that pubis symphysis, because they have given the birth, so the labor pains were more higher as a normal delivery. So after that, they feel this uncomfortable feeling. So in this, sometimes we check that there is a dysfunction related to pubis symphysis, and when there are some patients who, when they are just coming back from their vehicles, like they are just taking their legs down. So that time they feel pain in their adductors because of there is some cause related to the pubis symphysis. And some people, when they are doing their exercises, like in the gym, they do the stretching, so that time also they feel pain. And one of my patient, whenever she complained, then whenever she changes her dresses, that the bottom dresses like jeans or robe, that time when she take her hip in the position, like in the hip flexion position, that time also they feel pain near about the pubis symphysis. So these kind of the clinical symptoms we see, because we know that, and yes, as you have already mentioned, that as a viscera also, when the patient is having a pelvic floor prolapse, they are having a urine incontinence, or maybe the any sexual health dysfunction, that time also they are having a pain in the pubis symphysis. Maybe the misalignment of the pubis symphysis also there, and because some patient who are in a sports related, so they play more their they do their stretching exercise more, so after that they feel the pain in the pubis symphysis, that just like a widening of the symphysis pubis. So these kind of the position we see as a clinician part, and as we pathomechanically we match that with the visceral organ, also the pelvic floor, because we already know that how the pelvic organs they are inside there. So how these pubis symphysis plays a very major role, and as well as their ischial tuberosity, because when they sit, that time also they feel pressure, and the same time when they feel the pressure in their ischial tuberosity, and they feel pain in the pubis symphysis also. So it means all these viscera, reproductive organ, pelvic floor or problem related problem, and as well as the stretching related problem. So that gives us the idea there is a one thing which is myofascial component with the pelvic floor muscle, which gives them the stability, or the main the core muscles, that is the weakness of the core muscles, that also plays a major role, and the ligament laxity, the instability of the ligament, because we know that the pubis symphysis itself, it all around the ligaments are giving them the stability, superior, inferior, and main the middle and lateral both side there is a ligaments which are giving them the stability. So our focus as a clinician, we check the ligament with the force closure, which we have mentioned in our earlier session. We give this kind of, and the form closure we check with the core muscles, we check with the their how their motor control, how their stability factor plays in the major role. So that is also, or how their incontinence, any micturition problem, and because of their kidney related, any urination related problem, because of that they feel the pressure there. So these are kind of the differential diagnosis is also needed whenever we see the pubis symphysis. And as a part of the manual therapy, we know that anteriorly this is the pubis symphysis, and posteriorly there is a sacrum. So the relation between the ligaments of sacrum to the pubis, that also plays a major role. So sometimes the sacral related problem is also the cause of the pubis symphysis. So these things also we have to check with the form closure, force closure, or the movement testing, so that we can check it and we can guide. And there are some compression forces that we test, or maybe the muscle contraction by giving the contraction. So we see that either the adductors they are having in the tightness, so the patient is having, or sometimes the people who are in the office job, their sitting job, and sometimes they control flow of urine for more time, so after that also they feel the tightness in their pelvic floor area. So because of that also they feel pain in the pubis symphysis. So these are a clinical picture as a symptoms in my some patient I have measured, and as per our pelvic manual therapy course, we have treated the pubis symphysis in some patients by giving them the glides, like whatever the manual therapy we use the muscle energy technique, we use the articular structure also, myofascial also, and as well as the neural also. So these are the things which comes in the picture as a multi-directional. Whenever we see the pelvis region itself, the differentiation is important here. What is the cause of my patient, so that we can treat it better as a pubis symphysis dysfunction. Yes, sir. Sir, you are muted.
Yeah. Symphysis pubis, you are highlighting about the diastasis. Okay. That is the separation of the both the pubis. Okay.
Yes.
And that especially happens post pregnancy. That after that it's not returning to the original integrity. Okay. Otherwise, you see that force closures you can check, or form closures. So just lateral to the ASIS, and you can approximate. Okay, anteriorly. So that becomes the form closure of the pubic symphysis. And pelvic floor contraction itself is force closure. the most important part here is pelvic floor contraction can create the pain. So definitely you are left with only the abdominal core muscles to activate, but that will not produce a major change on the pubic symphysis symptoms. As you know that the joint itself is symphysis. So symphysis will not be influenced that much by muscles. Okay, it is more of osteocartilaginous and ligamentous. Okay, fibrous. It's a fibrous joint. Fibrocartilaginous joint, it has at least millimeters of mobility. Pubic symphysis mobility is only in people who have adolescent ligament laxity or the hormonal imbalances or abuse. Okay, the abuse which we highlighted, that even gym workouts to sexual or it is urinary tract infections, and of course repeated childbirths. Okay, or even these laparotomies. Okay, so there are surgeries which are extensively, especially the rectus abdominis, because the rectus abdominis muscle comes from the pubis and it goes all the way to the xiphoid process. Okay, both the rectus abdominis. And then the next one is, this is origin, okay, rectus abdominis. Insertion is psoas minor. So that is also on the pubic rami, superior. Whereas the inferior portion is much more actually outer portion and inner portion. Inner portion is the pelvic floor fully, whereas the outer portion is all the adductors of the hip. Obturator externus from the membrane, okay. Obturator internus is also there, okay, posteriorly. Okay, so that we can see here is actually an obturator internus with the superior and the inferior gemelli. Okay. The pubic symphysis, yes, inguinal ligament tenderness is a characteristic feature, because whether the affected side pubis is high or down, okay, which we call it as superior and inferior dysfunctions. Inferior dysfunctions, there will be a pulling of the inguinal ligament itself. So you will find that it is very taut, hard, and it is painful and tender. And you might find that the spasm of psoas minor can be there, coexisting. Because if the spasm not there, more pulling of the inguinal ligament will happen. Okay, because this will go more down. And the next one, this will go down when, that we'll see that kinematics. Otherwise, if you see superior one, the inguinal ligament will not be the primary pain producing structure, but when it is superior, all the what is called as the visceral structures here, they will get what is called as compressed. Okay, the compression effect. And because the viscera is getting compressed, the ligament will be like a rubber band. Okay, you push the rubber band, what will happen? It will become lengthened. It's not like elongated because of gravity that is pulling. Okay, that is like inferior shear dysfunctions. In superior shear dysfunctions, the inguinal ligament is elongated because of the viscera. Okay, so both the ways inguinal ligament will be tender. And the next one, anterior and posterior. So that means you have the pubis symphysis one side being anterior like this, affected side. Other side, of course, posterior like this. How do you find the affected side? Yes, patient tells pelvic floor symptoms, or it is lower abdominal symptoms, or directly at the pubis symphysis. But how do you know whether which side is the dysfunction? Whether it is right is high or the left is low. Okay, so that is where you come to that same finding of the pubis symphysis being continuous with the ilium, and we palpate the S2 and the PSIS. So that means for iliosacral dysfunctions, the motion palpation testing, what we do as the Stokes test or the Gillette test, as we move the hip, we palpate the PSIS with respect to the sacrum, compare it with the opposite side. Normal side, there is a relative mobility. Affected side, both are moving together. Okay, so that we know that that is the side of dysfunction. So then the corresponding side, that pubis will be said to be in the dysfunction, which is again confirmed by the tenderness of the inguinal ligament, and of course the muscles above and below the pubis, which is also in the corresponding dysfunction. So that means you might have psoas minor spasm, okay, because it is lengthening in an inferior shear, and the adductors may be that culprits which were poorly flexible, and that overactivity created the dysfunction. For example, a gymnast who is doing a leg spread, okay, or stretching is done in the gym, during that the subjects get cramps because that stretch is either done too fast or the muscles are poorly flexible, okay, so that pain as a response also there will be a cramp that will come. So that itself will produce a dysfunction of the pubic symphysis, okay, and you will find that the symptoms will be vaguely reported because this area is innervated by multiple, right from abdomen that is above, pelvic floor from below, and the hip which is from anterior, okay. So you always get the overlap of the innervations. So you will find that the pain distribution will be very vague. Patient will not be able to localize. That's why palpation is important. And you see that, okay, this pubic tubercle, okay, this is whether it is superior or it is inferior. This is at rest. And then you palpate the pubic tubercles, both the pubic tubercles. And then you ask the subject to move the hip into flexion extension, okay? Because the pubis which is superior will allow flexion, but it will not allow extension. If pubis which is inferior, it will allow extension, it will not allow flexion. And the same way, if the pubis is superior, it will allow abduction but not adduction. Pubis inferior will allow adduction but not abduction. And pubic diastasis, which is like one side normal, this side alone diastasis, okay, it is opened up or separated. So in that situation, the same side internal rotation will be restricted. External rotation will be allowed. So these things, again, you have to do the hip examination, and not only hip examination, palpate the pelvic tubercle and then move the hip, okay, so that you get that what is the dynamics that is happening at the pubic symphysis, okay. I think it's the 6 o'clock syndrome happening at Delhi. Okay. Yeah. Okay. Delhi evening 6 o'clock syndrome. And then this is again, so palpating pubic symphysis during the lower extremity movements, and for force closure will not be that much reflecting the effect. Only form closure can detect. And the next one, if rectus abdominis you are contracting, okay, like bilateral SLR, active SLR, so that will produce again shearing force on the pubic symphysis, okay. The dysfunctional side will go more higher, or it will be restricted from going higher. The posterior tilt will not come. When you ask the subject also to perform a posterior and anterior tilt, you will get reproduction of symptoms anteriorly, okay. So all this will denote that it is the pubic symphysis dysfunction. Whether Ritu ma'am is able to see me? Yes, yeah. So, and get the comprehensive picture. And as madam was highlighting, more than the sacrum, pubic symphysis dysfunctions occur together with the iliac dysfunctions, okay. So if you have iliac dysfunction which is anterior, pubic symphysis will be inferior, okay. Iliac posterior rotation, pubic superior. Iliac upslip, this also superior. Iliac downslip, this is also inferior. And Of course, the principles of evaluation follows the same. You want to differentiate between tightness and tautness, because tightness is shortening, whereas tautness is lengthening. Which people will have already lengthened adductors? Very rare. Okay, unless it is gymnasts who are stretching right from childhood. So those are the people who will actually have the diastasis. Okay, and the same way, trauma in adolescent age group, because of repetitive pull of the adductors, we get osteitis pubis, the same traction apophysitis, okay, at the pubic tubercle, and that again can create asymmetric forces, and at a later stage pubic symphysis dysfunction can come if iliosacral dysfunction comes. Okay, so whenever with the lower limb movement or squatting, if the groin is paining, definitely your primary should be iliosacral, not sacroiliac. Sacroiliac comes with the forward bending and twisting movements of the spine. Okay, or even in the full squat position, if rotation is done, then sacrum can come. Unless the trunk is involved, the spine is involved, vertebral column is involved, sacroiliac dysfunction will never come. Okay, it is always the iliosacral which will be coming. Okay, and see that if the lower extremity activities are producing groin pain, like cycling, it's producing at the pubic symphysis. You know that it's a lower extremity activity. So ilium only will be coming first, because you see that symphysis, it's a fibrous joint. It will not go for dysfunction that easily. Fibrocartilaginous is there, that will go for dysfunction. Although sacrum is synovial, it is not biomechanically interlinked with the lower extremity activity. Okay, so sacrum is related to the vertebral column. When vertebral column movement is happening, first priority will be sacrum and sacral dysfunction. Lower limb is happening means fibrocartilaginous will be the first option. Fibrous will happen if there is a vulnerable factor before, previous trauma, previous osteitis pubis, ligamentous laxity, inguinal hernia, prostate hypertrophy, even a visceral dysfunctions. Okay, so that can actually predispose the somatic system to be vulnerable for a dysfunction, because the visceral fascia are already asymmetric. And adding on the pelvic floor imbalance, which may be either the effect of the pubic symphysis or pelvic floor dysfunction itself, will add on to cause the pubic symphysis dysfunction. Okay, so that is when we contract pelvic floor, we see the symmetry of the contraction, whether there is a deviation of the pelvic floor during the contraction, or with the pelvic floor contraction, whether pubic tubercles are changing, whether the asymmetry that is there in the pubic symphysis is getting corrected with the pelvic floor, or it is getting exaggerating with the pelvic floor. If I am palpating at the pubic tubercle and pelvic floor contraction is aggravating the dysfunction, it means that the pelvic floor requires the release or the muscle energy techniques. That's the primary. So I have to treat that. If I am palpating, I am activating the pelvic floor and it is getting corrected, that means pelvic floor was weak because of the dysfunction, and pelvic floor training alone could be a treatment for effective adjunct, the force closure for the pubic symphysis. Okay. So limb lengths, as per the iliac dysfunction that is coexisting, the limb length discrepancy will come, and I can say the complication of this treatment is mainly because of the vulnerability of the viscera and the pelvic floor, and the location of this joint, which is like culturally or gender wise affecting the patient therapist interaction or the cooperation. Okay. Otherwise, definitely a knowledgeable, sensible therapist can easily treat the pubic symphysis dysfunctions. We have used the hip abduction, hip flexion, hip extension, internal external rotations as components when we are palpating the pubic tubercle, reaching the barrier, and then activating the particular muscles so that the muscle energy techniques of post-isometric relaxation itself will correct the pubic symphysis. And the same way, if you want a spasm is coming when you are moving the lower limb, immediately you can use the reciprocal inhibition, take the patient out of the spasm and be able to help the patient better. Okay. So that's about the pubic symphysis. If you are seeing the neural component, the inguinal ligament, femoral nerve, and of course the obturator foramen, the obturator nerve together with the abductors, of course, it's very important. Whenever people tell symptoms along the thigh, okay, which is going down below the hip joint, do not assume that it's only muscle, okay. And the next one, because of L2, 3, 4, the femoral also, obturator also, L2, 3, 4. You might find a quadriceps weakness on the same side as long as there is a pubic symphysis dysfunction, okay. So which may be a silent one, old dysfunction which is not corrected, patient got adapted to it, living with it, forgot about it, and then later you will find osteoarthritis knee, okay. So that can come. And the same way, pelvic floor also is another neglected area. So which may be primarily pelvic floor, then the pubic symphysis, or primarily pubic symphysis dysfunction, then secondarily pelvic floor. That is an independent problem, okay, chronic pelvic pain, okay. So get sure that you are getting a better, deeper insight into the different muscles of the pelvic floor. Many courses are provided by many people, but ensure that do the courses which are like meaningful, in the sense every muscle, how it can be directly or indirectly released, whether they can be activated together with the release, whether you require antagonistic muscle activation during the release, whether we can use IASTM for the pelvic floor, whether you can use the cupping or even stimulation for pelvic floor, how all you can modify and use it as per the corrected position of the dysfunction, okay. Because you keep the leg in the corrected position, then you do. And if the subject tells, for example, hip abduction, that means stride stance. So standing with abduction, and then you can rotate the trunk, okay. Various you can do, mechanically, kinematically, okay. You can modify the rotations also, hip rotations, internal, external, and then do the trunk rotations, so that influence the iliac bone and recheck the symmetry of the pubic symphysis, okay. So that's about the pubic symphysis. I think our Sujanya has just come into this, okay. She may not be ready to come on the screen. If she was ready, she could have come, okay. Yeah. So it must be a long day again for her, right? So Rita ma'am will summarize, and then we'll close this session for the pubic symphysis dysfunctions. Yes.
Yes, sir. I think you have highlighted so many points, which is very important to do the evaluation and assessment, because while doing the evaluation and assessment, we get the idea that in which direction we are going to use it according to their direction of how the iliac dysfunction can be the cause for the pubic symphysis dysfunction. That is, the clarification is very clear from your side. And yes, the movement testing with their muscle simultaneously with the muscle contraction can give us the better idea that yes, in which direction we have to work. Either we need a articular treatment or we need the myofascial treatment. And with the core muscle, with the rectus abdomen, how we can see, this is also very important, because after the C-section, after the delivery, this relation is very important to see with the rectus abdomen, and always with the adductors, how it can be related with the pubic symphysis dysfunction whenever the patient is having. And all the functions like with the abduction, adduction, and extension and flexion of the hip, all is related to check with the pubis symphysis dysfunction. Then it can be if there is a need of the correction, if there is a misalignment, so how we can give the gliding and we can correct it by checking simultaneously with the myofascial contraction also, in which direction we have to work. That has very in a simple way you have clarified. And I think this area is very much ignored, that people don't want to treat the pubis symphysis dysfunction. They keep it as for the part of the gynecologist, that or maybe for the male for the urologist. So they don't want to touch it. Although we treat the sacroiliac or iliosacral, we know that how we can manage. But this kind of the situation, we normally as a physiotherapist, we take out from this situation. We don't want to go inside. But as the AOMPT view, we cannot leave our patient if they are in the pain, or we have to check in this also aggravation versus the relieving factor, in which direction by giving the force, or which direction with the muscle contraction my patient is getting a relief. So my focus is all there with the relieving factor, either with the treating with the muscle energy technique to relieve the spasm, and then I can give the articular technique. And by keeping the patient in the neural position where the femoral nerve, sciatic nerve, obturator foramen, obturator nerve, we cannot forget the all side of the nerves which are also, because sometimes the patient feel pinching pain, sometimes they feel the numbness. So these things also very important to observe, that either the articular, myofascial and neural, which is the primary here, which is the secondary and tertiary. So that I think the neural assessment, normally people leave it. But in this case also pubis symphysis, we cannot leave this neural component, because that neural component give them a more problem in the brain to the patient, that why I am feeling the numbness in that area, because of that nerves which are passing through. And the same thing which you have added, that after some time the patient is having with the knee problem, OAE knee, because of the same root values with the lumbar to the knee, and for the femoral nerve and all the nerves related to that area. So these things very important as all the component. And in this also we need to convince the patient with the central sensitization also plays a major role, because of the sensitivity of the part. We cannot say that patient it's not a problem after delivery or after the surgery it happens. We have to give them a proper treatment with the pain-based mechanism also, if there is a need of that. So these time, because sometimes there are some other problems also create a pubis symphysis dysfunction because of some sexual dysfunction. They feel the problem. So these things also we have to be clarified, that yes.
The domestic violence also. Okay.
Yes. So
some,
these things also we, yes. So we have to match all these also these things, because this area we cannot ignore. And as a female therapist, it's my duty, if my patient who wants to discuss her problem, so I have to work on that. Yes, how I can take her from this problem out, and I can treat it better with the perfect planning of the treatment with the evaluation and assessment. So thank you so much, sir, for highlighting all the points that articular, myofascial and neural, which is important to treat the pubis symphysis, is mandatory part if the patient is having a problem related to the pelvis. So differentiation with or relation with the ilium dysfunction is very important to treat the pubis symphysis. Yes, sir. Thank you, sir.
Okay. Because many people think that we correct the, ilium, we correct the muscle imbalances in the legs, so automatically pubis symphysis will get corrected. Okay, you don't have to specifically treat. That is where it becomes a silent killer. Okay, if you don't actually address this, then it becomes consequences on lower limb, or it becomes like central sensitization, as you highlighted correctly, that chronic pelvic pain alone is a separate central sensitization syndrome. Okay, because the genitals are represented larger area in the sensory and also in the motor cortex. Okay, the representation area itself is big, and has functionally also urinary, reproductive, sexual. So all the three are in the male. You see that all the three are together. Okay, so that again creates functional impairments to be interdependent. Okay. So functional dysfunction, what to say, limitations to be interdependent. Okay. So explore this region, and most importantly, see the relationship. Do not forget to palpate the pubic tubercles, whatever we do. Okay. So we move spine also, we can palpate and see which is correcting. So that will give an idea of external internal oblique imbalance. Okay, how it is having a role. And when we move the lower limb, ipsilateral or contralateral also, how it is correcting the symmetry. Okay. So after, of course, treating the iliosacral. Okay. If there is both the dysfunctions are present, you have to know which one is primary. Okay. So if there is a pelvic floor postnatal, then pubic symphysis is expected to be primary. Or it can be visceral dysfunctions, visceral disorders, abdominal surgery, then pubic symphysis is primary. Because that will not affect the ileum that easily. Okay. Otherwise, if you see lower extremity, muscle imbalances, okay, and a poor posture, prolonged sitting, bike riding after a long time, after that having pain here in the posterior gluteal region, you might think it's a piriformis syndrome. You might treat the piriformis, but you may not get that long-lasting recovery. Then you have to definitely focus on the iliosacral, because that is the iliac dysfunctions. Okay? So they play a part in spinal movements and also lower extremity movements, but your focus is on the palpation of ASIS and the PSIS. Okay, so primarily this relative motion with the opposite side. Even during a muscle contraction, how it is, the same principles. Okay, right. So we can close this session on the pubic dysfunctions and see if we need to resume the third, or we'll wait for tomorrow for the sacrum dysfunction as per what we finalized with Ritu ma'am, and also I don't think Dr. Sujanya will be able to join now in the third webinar, although it is almost midnight for Dr. Sujanya there, right? So we can close the session. See you, and wishing all the participants who are watching, take your step, do the best courses, genuine academy, valid certification. The choice is all yours. God bless you all.